So hello, we are doing pediatric radiography session, and so we are here for the hip radiography. Symmetric positioning is crucial, and wet diapers should be removed because they can produce significant artifacts produce करते हैं, and children on stretcher may be examined without moving them to the table by skilled radiographs. So जो चिल्ड्रंस होते हैं स्ट्रेचर्स पे उनको एग्जामिन करने के लिए विदाउट मूविंग देम टेबल बाय स्किल्ड रेडियोग्राफ्स किया जा सकता है. एंड ए क्रॉस टेबल लैटरल व्यू इज ऑब्टेन्ड इंस्टीड ऑफ ट्रेडिशनल इन्वर्टोग्राम ऑफ ए चाइल्ड विद द imperforate anus should no longer be made for GIT procedure. Children less than 2 years should never be kept fasting longer than 3 to 4 hours before the examination. And for intravenous urography, make a conscious effort to keep number of exposures to the minimum, and infants may fed once contrast has been injected. And now mammography. So mammography is a special radiography exists to demonstrate the soft tissues details of the breast. Mammography एक स्पेशल रेडियोग्राफी डेमोन्स्ट्रेट करने के लिए सॉफ्ट टिश्यूज डिटेल्स ऑफ द ब्रेस्ट, and this technique is called mammography and is carried out with a dedicated specialized radiography equipment called mammography equipment. And anatomy of the breast. So breast or mammary glands is a hemispherical soft tissue structure located in the chest wall from the second to sixth rib, superficial to the muscles, and size varies with age and under effect of hormones, menstrual cycle, pregnancy, and lactation. And the nipple is a small projection containing a collection of duct opening from the secretory glands within the breast tissue, and the dark area surrounding the nipple is termed as the areola, and the junction of the inferior part of the breast with the interior chest wall is called as the inframammary crease. And axillary tail is a band of tissue that wraps around the pectoral muscle laterally, and the width of the breast greater than the vertical measurement. So the large pectoralis major muscle overlies the whole thorax. जो large pectoral major muscle होती है overlie करती है whole thorax में, and a fibrous sheath surrounds the breast below the skin surface and also covers pectoralis major muscle, which joins in the retromammary space. And the retromammary space must be demonstrated at least one projection during the radiographic study of the mammary gland. So two basic views are taken for the mammography are CC craniocaudal and mediolateral oblique view, and technical factors used are 8 to 10 film size and crosswise 10 12 in crosswise, and moving grid used होती है, and 25 to 28 kVp यूज होता है. And पेशेंट पोजीशन स्टैंडिंग और सीटेड इन ए स्टूल में होनी चाहिए. एंड पार्ट पोजीशन फॉर क्रेनियोकाउडल प्रोजेक्शन. Film tray height is determined by the lifting the breast to achieve 90-degree angle the chest wall, and tray will be at the level of inframammary crease as its upper limits, and the breast pulled forward into the film holder centrally with the nipple in profile, and the head is turned away from the side being imaged, and wrinkles and folds on the breast should be smoothed out and compression applied, and the marker and the patient ID information is always placed on the axillary side and central race, and so perpendicular center to the base of the breast and chest wall edge of the cassette, and is suspended breathing. So side is fixed in machine approximately 60 centimeter. And mediolateral oblique view. So technical factors are 8 to 10 inches film size, or crosswise 10 to 12 inches crosswise, and moving grid used 25 to 28 kVp, and patient position standing or sitting on a stool, part position, and tube is angled about 45 degree to that the central ray enters from the medial side of the breast perpendicular the patient's pectoral muscle, and film holder height is adjusted so that the top of the film will be at the level of axilla, and patients hold the bar on the side of the unit with hand so that axillary fold is placed on the cassette, and the push the patient slightly towards the angle film holder and pull breast to tissue and pectoral muscle interiorly away from the chest wall, and until the inferior lateral aspect of the breast is touching the film holder. Apply compression slowly with the breast held away from the chest wall, and the upper edge of the compression device will rest under the clavicle, and lower edge will include the inframammary fold. Wrinkles and folds on the breast should be smoothed out, and adequate compression should be applied, and the marker should be placed high at the axilla and central ray, so perpendicular centered to the base of the breast at the level of chest wall, and SID should be approximately 60 centimeter, and patient should remain immobile, suspend per breathing while exposure is being made. Okay, so रिव्यू क्वेश्चंस आर हेयर, जो हम लोग ने पोजिशनिंग की है उससे रिव्यू क्वेश्चंस हैं ये सभी. सो यू गाइस कैन आंसर दीज, एंड वी विल स्टार्ट फ्रॉम द स्पेशल रेडियोग्राफिक प्रोसीजर्स. और अभी हम लोग स्पेशल रेडियोग्राफिक प्रोसीजर्स देखने वाले हैं. सो दीज आर एक्सक्रीटरी सिस्टम, biliary system, GIT, angiography, myelography, and miscellaneous. So here we will elaborate the radiography procedures for the excretory, biliary, GIT reproductive system, and demonstrate the procedures of the excretory, biliary, and GIT reproductive system. So urinary tract. So urinary tract consists of the kidneys, ureter, urinary bladder, and urethra. So the radiological procedures used to diagnose the abnormalities in the urinary tract are IVU, intravenous urography, retrograde pyelography, RGP, antegrade pyelography, AGP, voiding cystourethrophy, VCUG, and retrograde urethrophy, RGU. So intravenous urethrophy, IVU. It is the investigation most commonly used for evaluation of the disorder of the urinary tract, kidney, ureter, and bladder, and it provides information regarding the kidneys, status of the kidney, as well as the functional anatomical information of the kidney and the pelvic-calcial system and the ureters and the urinary bladder. However, it is not advisable to do in the patients with previous reaction to the contrast media, pregnancy, multiple myeloma, और overt cardiac और renal failure. सो पेशेंट प्रेपरेशन इसमें क्या क्या की जा सकती हैं या फिर की जानी चाहिए, वह प्रिलिमिनरी प्लेन एक्सरे प्रीरिक्विसाइट करेंगे, फॉर द KUB करेंगे, APV फॉर द प्रॉपर bowel preparation is must before IVU, and laxatives and gas absorbent 2 Dulcolax and 6 charcoal tablets are given on the night previous the examination to adult, and the patient is kept fasting on the morning of IVU, and a blood urea and serum creatinine level report to show the functional status of the kidney should be available before the planning and IVU, and history of allergy to the drugs and contrast medium, and any history of significant systemic illness of cardiac, respiratory disease system, or as like asthma is must have any asthma is a must before any IVU study, and for elective or pre-planned IVU study, the menstrual history of a female patient must be taken, and the study planned during the safe days 10-day rule should be followed period of the menstrual cycle, and in an informed consent of the patient must be taken before giving contrast, after explaining the risk of contrast reaction to the patients. And procedure: on the day of IVU study, a scout film X-ray KUB-AP is taken to see the bowel preparation, to judge the exposure factor and confirm the position of the calculus or work of the abnormality already visible on the previous plain X-ray film. So contrast medium: approximately 40 ml of urographin 76% is given as a bolus intravenously in adults with a normal renal function, and इन चाइल्ड्स अबाउट 1 ml पर kg के हिसाब से बॉडी वेट के हिसाब से यूरोग्राफिन 60% इज गिवन इन हाई रिस्क पेशेंट्स और विद अंडरलाइंग डिसीज लाइक डायबिटीज़ और ए नॉन आयनिक कंट्रास्ट मीडियम लाइक आइहेक्सॉल ipomidol should be used, and the contrast is injected IV as a bolus, observing patients for any signs of outward reaction. In case of any reaction, the injection is stopped and radiologist must be informed and immediately appropriate measures taken. For most mild reactions, reassurance antihistaminic drugs injection is sufficient, while for moderate and severe reaction, appropriate measures need to be taken, and abdominal binders, if applied, must be released, and ABC should be evaluated and restored as soon as possible. ABC is the airway patency, breathing and circulation, and the vitals like pulse, blood pressure, respiration and level of consciousness of the patient must be examined and recorded, and intravenous drip must be started immediately. Oxygen should be given by intranasal catheters or mask, and doctors must be assisted in giving medication through appropriate route as required. So filming sequence: the first two films are taken for renal areas crosswise 1 minute and 5 minutes from the time of injection with cassette 10-12 placed, and abdominal binder may be applied across the patient's abdomen after 5 minute film, and this helps to retain the contrast within the pelvic calcium system and the ureters for better visualization. However, the binders is omitted in children patients with the abdominal mass and suspected renal injury. Further films are taken 12-15 cassette for the whole cubic and region after releasing binder 10 to 15 minutes after injection. Sequence of films is taken 1 minute. 10-12 nephrogenic phase shows the renal function, and 5 minute pylographic phase shows contrast excretion into the pelvic calcium system, and therefore 10 to 15 मिनट 12-15 में बाइंडर रिलीज होगा, and film for KOB region, and prone film is taken to visualize the lower ureters if not seen in previous film, and full bladder 10-8 मिलेंगे for urinary is followed by radiologist bladder post wide bladder film, and each film is processed immediately after exposure and seen before next film is exposed. And oblique views under fluoroscopy may be required to show the relationship of the radio opaque shadows of the urinary tract, whether it is calculus or lymph node lying outside line of ureter. So delayed films after 24 or 48 hours may be required for the demonstration of functionality and of the impaired kidneys. An injection lasix may have to be given. lasix देंगे for given intravenously during the procedure to confirm the rule out the diagnosis of pelvic ureteric junction obstruction. So that pelvic ureteric obstruction junction को चेक करने के लिए. So this is the 5-minute film. ये 5-minute फिल्म है. इसमें पेल्विक कैल्शियल सिस्टम में पहुंच गया है. एंड दिस इज द 15-minute फिल्म प्रोन ऑफ द एब्डमन प्रोन फिल्म है. एंड नाउ रेट्रोग्रेड पाइलोग्राफी. When IVU fails to demonstrate the whole part of the ureter and when ectopic ureteric openings are seen, so demonstration of course of ureters is done by injecting contrast directly into the. जब IVU फेल हो जाता है डेमोन्स्ट्रेट करने के लिए होल और पार्ट ऑफ यूरेटर को चेक करने के लिए एक्टोपिक यूरेटरिक ओपनिंग देखी जाती है और डेमोन्स्ट्रेशन होता है कोर्स ऑफ यूरेटर इज डन बाय इंजेक्टिंग कंट्रास्ट डायरेक्टली इनटू द यूरेटर. सो इट्स ओपनिंग इनटू द urinary bladder and it is contraindicated in an acute urinary tract infection and the catheter is selected. Ureter is put by urologist and cystoscopically. The catheter is retained by fixing it with the tapes and under fluoroscopic control contrast 8 to 10 ml Conrad 280 is injected into the catheter and films are taken demonstrating the ureter in the entire length till the pelvic calcial system and any obstructing into it obstruction को देखने के लिए. Now antegrade pyelography. So this is the antegrade pyelography image done through the nephrostomy with tube showing dilated calcial system and proximal ureters. So when nephrostomy has already been done on a patient for a drainage procedure or percutaneous nephrolithotomy or when RGP is not possible because of the difficulty in catheterization of the ureter, antegrade pyelography is done. So in post-operative cases of ureter implantation also this study required as RGP is not, retrograde pyelography is not possible. So nephrostomy is performed under ultrasound or fluoroscopy guidance. So contrast 8 to 10 ml of Conray या 280 या urography 60% is injected under fluoroscopy guidance and the needle is positioned in the nephrostomy tube which is clamped distal to the needle and the head end of the fluoroscopic table may need to raised facilitate flow of the contrast through the ureter and films are taken under fluoroscopic control to demonstrate the course of ureter. So this is the nephrostogram and cystography and micturating cystourethropy MCU or widening cystourethropy. So this is the cystography image, widening cystourethrogram and patient is supine on the radiography table. Diluted contrast 50% dilution Conray 280 is used and contrast is instilled via suprapubic catheter in situ or via catheter inserted in per urethra. Films are taken in AP and both oblique positions to demonstrate the urinary bladder को demonstrate करने के लिए. If an obstructive disease is at the level of urethra is suspected or evaluation for vesicoureteric reflex is required. So VCUG vesicocystouretherogram is performed in which the patient is asked to micturate while lying on the table. इसमें टेबल पे लेटे हुए मिक्चुरेट करने को बोला जाता है. एंड फिल्म्स आर टेकन अंडर फ्लोरोस्कोपी ड्यूरिंग micturation as contrast fills the urethra, and post-voiding films are taken to access the residual urine in the bladder. And retrograde urethrophy RGU. So when the patient is unable जब पेशेंट अनेबल होता है टू मिक्चुरेट ड्यू टू द यूरेथ्रल ऑब्स्ट्रक्शन, द एंटीरियर यूरेथ्रा इज delineated and injected contrast through a catheter whose tips is positioned in distal tip with the urethra, and alternatively Foley's catheter with its bulb inflated and navicular fossa is used to instill the contrast. So contrast is injected under fluoroscopy and films are taken in oblique positions to show the anatomy and penile or bulbar urethra. So this is the RGU, retrograde urethrophy, to see the urethra. And now biliary tract. So the biliary tract comprises of the gallbladder, intrahepatic biliary radicals, extrahepatic bile duct. Contrast studies needed to radiographically study the biliary system of the diagnosis. Various disease conditions are percutaneous transhepatic cholangiography PTC, endoscopic retrograde cholangiopancreatography, preoperative cholangiography, and T-tube cholangiography. So with the introduction of ultrasonography, the initial modality for evaluation of the biliary tract is ultrasound, so which is non-invasive and non-radiating. So radiological investigation of biliary tract is oral cholecystography. In modern radiology practice, there is no role of oral cholecystography, which was used in demonstrating gallstone in the gallbladder in the past. पहले इसका यूज होता था, अभी यूज नहीं होता है. गॉल ब्लैडर की स्टोन्स के देखने के लिए करते थे. एंड it has been replaced by ultrasound, which is much simpler, safer, non-ionizing, quicker and more accurate. And the contrast is given orally in the form of tablets which is excreted through the bile and reaches the gallbladder. And intravenous cholangiography, so IVC, this is the procedure requires the use of intravenous contrast medium to opacify the biliary tree, and it has now abandoned because of high chances of developing कंट्रास्ट रिएक्शन. इसमें कंट्रास्ट रिएक्शन का चांसेस बहुत ज़्यादा होता है, इसलिए इसको भी छोड़ दिया गया. एंड अवेलेबिलिटी ऑफ द बेटर अल्टरनेटिव्स टेक्निक्स फॉर इवैल्यूएशन ऑफ biliary सिस्टम, और इससे बेहतर टेक्निक्स भी हमारे पास अवेलेबल हैं. डायरेक्ट कोलेंजियोग्राफी टेक्निक्स हैं PTC, परक्यूटेनियस कोलेंजियोग्राफी एंड RGP are available. So although they are still the most sensitive methods for demonstrating nature and extent of biliary pathology, use of direct cholangiography appears to be declining due to its invasive nature, and simultaneously development ultrasound, CT, MR imaging. The biliary tract is non-invasively studied by these techniques. So because of the risk of complications, discomfort and limitation of availability and cost of PTC and RGP, these techniques are used after non-invasive techniques like USG and MRI confirm obstruction of the biliary tract and require intervention like removal of stone from the common bile duct and need for biopsy, biliary drainage, and patients with malignant obstruction is required. And percutaneous transhepatic cholangiography, so patient preparation, 6 to 8 hours fasting is required before examination. Hemoglobin, prothrombin time and platelet count are checked. Any indication for increased risk of bleeding is corrected, and prophylactic antibiotics is given 24 hours before and continued for 3 days and after the procedure. So the procedure, patient is asked to lie supine on the X-ray table and taking aseptic precautions. Chiba needle is introduced through a skin puncture in mid-axillary line and into the central transhepatic duct under the fluoroscopy and ultrasound guidance directly through the liver substance. About 20 to 40 ml water soluble iodinated contrast is injected to fill the dilated biliary radicals and patient position is adjusted to fill the ducts and the needle is withdrawn and films are taken in supine, prone and oblique and erect positions. So vitals are pulse, respiratory rate, BP checked and recorded. Patient is restrained in bed and 24 hours. So complication क्या क्या हो सकते हैं इसमें? इन्फेक्शन या सेप्टिसीमिया के चांसेस हो सकते हैं, ब्लीडिंग एट द साइट ऑफ द लिवर पंक्चर एंड बाइल लीकेज एंड पेरिटोनियल कैविटी एंड हाइपरटेंशन हो सकता है. सो एंड एंडोस्कोपिक रेट्रोग्रेड कोलेंजियो पैनक्रियाटोग्राफी क्या है? सो दिस इज द एंडोस्कोप रेट्रोपेन कोलेंजियो पैनक्रियाटोग्राफी का इमेज है. ERCP in situ with contrast filling CVD pancreatic ducts. So what are the preparation? We will continue from here in the next video. So till then keep study hard.